Everybody. At the outset, I would like to thank Dr. Vashni for involving me in this IC. So as most of it is covered, I would just touch upon some rare syndromes which we encounter in our daily practice. So this was a 2.5 years old female who presented to us with lid edema, and on careful examination, we could see it was a soft swelling over the upper lid with corneal haze, and also on systemic evaluation, there were some hypopigmented patches on the trunk. They carried some old reports which they were elsewhere diagnosed with congenital glaucoma, ectropia on UVA, and the MRI orbit showing ophthalmos and proptosis. No doubt with the constellation of all these signs, we would think that this is a case of neurofibromatosis, which was further confirmed on our genetic evaluation. So neurofibromatosis belongs to a group of phacomatoses, which are actually heterogeneous group of multisystem disorders, and that share a predisposition to develop hematomas within the CNS, often in association with cutaneous, ocular, or visceral lesions. The other entities under this group are NF2, Sturge-Weber, tuberous sclerosis. So basically, they are actually due to a disturbance in neural crest migration, where NF1 is commoner than NF2, and the mutation is in gene chromosomes located at chromosome 17 and chromosome 22. The ocular features which we would see in these cases, apart from the systemic ones like capillary spots, freckles, which are some hyperpigmented in risk patches at the areas of friction, and there would be cutaneous neurofibromas. The plexiform neurofibroma of the upper lid giving a lazy S deformity, leash nodules which are avascular clump over the tissue over the iris, and the optic nerve gliomas, sphenoid wing dysplasias causing temporal part prolapse and a fullness of the temporal fossa, and this unidentified bright objects which are hyperintense lesion along the brain, but they do not have any clinical significance. So these are the other manifestations which are seen and reported in various cases like hypertelorism, proptosis, corneal edema, ophthalmos with or without increase in pressure, ectropia on UVA, retinal hemangiomas and vascular occlusion, choroidal neuromas, disc edema, and all this leading to amblyopia in association with strabismus. So bilateral optic gliomas are present, which would cause disc edema. They were seen as tubular swellings in the T2 section. The optic nerve sheath does not run parallel. However, it is a fusiform swelling, and there can also be multiple focal hyperintense lesions in the brain. If a disc edema is present in presence of proptosis, it gives us a clue that it is an optic disc glioma. However, if it is without proptosis, this could be secondary to hydrocephalus or a chiasmal glioma or hydrocephalus associated with aqueductal stenosis. Finally, they would lead to optic atrophy at the primary or secondary. If these gliomas are present along the other cranial nerves, then they would cause cranial neuropathies, headaches, and additional neurological symptoms. In 40% of the cases, they would have intellectual impairment, learning disability, and hyperactivity. In NF2, ocular features are less, but what are the ocular features? Are posterior subcapsular cataract or cortical opacity, and they would present with lesion resembling epiretinal membrane with macular pucker or combined hematomas of the retinal pigment epithelium. They would present with papilledema in the present because if there is presence of optic nerve meningioma, which would present as disc edema. The classical appearance of optic nerve meningioma is a visual tram track sign where they run parallel. The optic nerve sheath is parallel, unlike the fusiform swelling of the optic nerve glioma. So this was another 3-year-old male who presented to us on his mother's lap with subnormal intelligence, the pigmented lesion over the face, and one can see the cataract as well as corneal edema there. A detailed evaluation of genetics shows that this child had Sturge-Weber syndrome. So these are sporadic congenital neurocutaneous syndrome with a triad of facial birthmark or port wine stain, abnormal blood vessels, and eye abnormalities like glaucoma. The treatment of this is depending upon the symptoms which are available. The neuroophthalmic manifestations here would have cortical calcifications which would result in seizures, and in T1 weighted scans they would have leptomeningeal vascular malformations and mild cerebral hemiatrophy. So they would present with homonymous hemianopia from occipital lobe involvement or glaucomatous optic atrophy and strabismus and an isometropic amblyopia. This is tuberous sclerosis. Touching upon its ocular manifestation, the most common is retinal astrocytoma. If it mainly involves retinal nerve fiber layer, when present closer to the disc, it would mimic as if it's a disc drusen and would cause pseudoedema appearance. Apart from this, they have a constellation of systemic features, and there can also be retinal achromatic patch. This was another 2-year-old male who presented to us with his parents, and we see there are a number of features here. On examination, he had central, steady, and maintained fixation, but poor attention span. What we see in these pictures is a prominent forehead with bony irregularity, chin down with left head tilt, marked proptosis, downslanting of palpebral fissures, and cleft palate, dental anomalies, syndactyly, ectropion with lower lid laxity, fornix prolapse with chemosis and exposure keratopathy both eyes, left exotropia, no excyclotorsion on fundus, and no evidence of disc pallor. All this gamut of symptoms as the signs which we see here, and a diagnosis brought us to think that it is Apert syndrome. So Apert syndrome belongs to craniosynostosis, where we have premature fusion of one or multiple of these sutures. Once they are prematurely fused, they would inhibit skull growth perpendicular to the fused suture, and there would be a compensatory growth parallel to the suture. The most common suture which has premature fusion is sagittal, giving us a boat-shaped head, or if it is unilateral, it will give us a plagiocephaly, anterior plagiocephaly, or a trigonocephaly, when the triangular skull shape with prominent vertical forehead ridge if the metopic suture fuses early. So what are the syndromes associated with these premature fusion? The most common which we encounter are Crozens, Pfeffers, and Aperts, and all of them would present with exorbitism, hypertelorism, and downslanting palpebral fissures in association with mid-face hypoplasia. And because of these orbital anomalies as well as skeletal anomalies, in these cases, they would always have excessive perspiration and respiratory difficulties. So the ocular sequelae here are strabismus, a V pattern, which is called as excyclotorsional strabismus. Refractive error, most common, is astigmatism. They would also have legophthalmus, as we saw, leading to exposure keratopathy and corneal scar. Finally, all these would have predisposition to amblyopia. So glasses and patching therapy, most of these kids would remove the patch because of the excessive sweating. When to do a strabismus surgery is a debate after the complete bony growth beyond 2 years or earlier than that. So excessive lubricants and lateral tarsorrhaphy is also done. Disc edema can be seen due to abnormal cranial shape or volume, ultimately leading to optic atrophy and vision loss. And the intracranial pressure measurement can be done with various methods as discussed. And emergency treatment in this condition is done when there is an elevated ICP. This was another 6-year-old female who presented to us with reduced distance vision. On careful examination, there was compound myopic astigmatism, vision was 6/9, and both eyes had mild subluxation. As we saw, there was no wrist sign, thumb sign, pes planus, but there was increased arm span to height ratio. She was accompanied by her mother, who had history of lens subluxation as well. She was tall and lean, and also carried a cardiac evaluation paper which showed that there was dilated aortic root. So in presence of ectopia lentis, superotemporal, increased arm span and aortic root dilatation, with the presence of a family history, we are sure it is nothing else than Marfan syndrome. So this is the most common syndrome associated with ectopia lentis, and it is an autosomal dominant with fibrillin 1 gene mutation. These are the ocular abnormalities in Marfan syndrome, which involves all of our structures and systemic manifestations as well. So cardinal features is supratemporal incidence is 60 to 80% with blood vision, monocular diplopia, posterior dislocation, and irregular astigmatism. With this, we need to differentiate them from the mass phenotype, which is myopia, mitral valve prolapse, aortic root dilatation, skin and structural abnormalities, as well as the contractural syndrome, and from homocystinuria, which would have an inferior dislocation in presence of mental retardation, and Will Marchesani, where there would be microspherophakia, ectopia lentis, brachydactyly, and thickened skin. So all of these would then also have ocular complications like corneal endothelial damage, decompensation, pupillary block, glaucoma, subluxated lens, dislocated lens, and also retinal detachment. Therefore, to conclude, in all these conditions, a meticulous history both of ocular and systemic, a detailed preoperative evaluation about the bony abnormalities, timely intervention to prevent amblyopia, and definitely a multidisciplinary team approach. But the care does not end without an optimal post-op treatment and rehabilitation, thereby giving a good life and a perfect visual outcome.